to take the decision.
Next is about the chronic pancreatitis. The chronic pancreatitis is just a variation of the acute pancreatitis. The only difference is, unlike that of an acute pancreatitis, it may not produce a clinical emergency. It may be a chronic condition. And the causes for that could be, it could be due to a obstruction in the duct, like very common cause would be the alcohol abuse. Patients who consume excess of alcohol, they tend to have fibrosis in the pancreatic duct, as well as fatty degeneration in the liver, and these can act together to produce an obstruction within the duct. So when the pancreatic duct is obstructed due to alcohol, or at times it could be due to stones or tumors, it can be producing the same effect. The pancreatitis also, chronic pancreatitis also could be triggered due to some chemicals, toxic substances, which could be produced due to either inflammatory diseases of the body, like rheumatoid pathology like conditions, or any other autoimmune conditions, or even it can occur due to the conditions like sprue, colitis like conditions, can trigger an immunological reactions where it will be mediated through the cells like neutrophils or macrophages, and the pancreas may get damaged. Oxidative stress also is supposed to be a cause for the chronic pancreatitis. These days, the intermediary metabolic products accumulated in the body due to improper digestion, particularly oxidative stress induced due to the variations in the food, and there too again the test makers that all that packing these preservatives used in the food, as well as test makers, they are known to produce harm to the pancreas. The fibrosis due to a previous pancreatitis, once there is a pancreatitis, it tends to produce fibrosis, and or even necrosis due to an acute pancreatitis can result in recurrent chronic pancreatitis. Ischemia, if there is a reduced blood flow to the pancreas, it also can result in the pancreatitis conditions. Autoimmune disorders also can produce like Sjogren's syndrome or biliary cirrhosis, or renal tubular acidosis also can result in pancreatitis. Alcohol is the most common causes of chronic pancreatitis. It's around 60 to 70% of them are there, whereas 20 to 30% are supposed to be idiopathic, where the real causes are not known. The other coexisting causes for chronic pancreatitis are patients who have a hyperlipidemia, increased lipid levels in the body, hypercalcemia due to, or hyperthyroidism, also hyperparathyroidism. Also, when the serum calcium level is very high, that can be a cause for chronic pancreatitis, including those who consume excess of calcium also. Nutritional or tropical chronic pancreatitis is also known to be present in some countries where the food habits would contain many irritant substances, like in Japan, where they tend to take more smoked fish like conditions. Many of the medicines also are known to induce pancreatitis. Clinical presentation would be recurrent episodes of acute pain is the most common symptoms, and they experience the pain at unpredictable intervals, while a minority of patients may experience continuous chronic pain. Characteristically, the pain is referred to the back, and the pain is often maybe even related to the food. Another quite common symptom would be steatorrhea, because the pancreatitis has occurred and the absorption or digestion of the fat is not proper. The fatty stools will be presented, and even diarrhea could be repeated loose stools. Weight loss also is a common sign of chronic pancreatitis. Investigations in case of chronic pancreatitis is serum amylase is marginally raised. Ultrasonography, of course, can make out the chronic pancreatitis, but CT is more reliable. In acute pancreatitis, ultrasonography is more reliable, whereas in chronic pancreatitis, because there is a chance of fibrosis or ductal obstruction, many times ultrasonography may miss it, whereas CT is more reliable. ERCP confirms the pancreatitis conditions, chronic pancreatitis conditions, And pancreatic test functions now are used to study the intestinal contents. Typically, there will be lesser pancreatic enzyme levels, and hence the fatty substances will be presented. The CT image of a chronic pancreatitis shows either a swollen pancreas with multiple calcifications or simply edematous areas present in the pancreatic area. Ultrasonography also shows the same thing, but the calcifications are better visible in a CT than in the ultrasonography. These ultrasonography CT images of chronic pancreatitis would be typically made out as such. Treatment, there is as per the current modern approach to treatment, there is no curative treatment in case of chronic pancreatitis. So all that goal of the treatment would be improve the clinical conditions of the patient, and most of the times it's left to itself so that the pancreas may heal by itself. To promote the pancreas by healing by itself, those irritant factors like alcohol or the food substances with them preservatives like packaged food substances, junk food, that has to be avoided. So diet control is one of the most important part of the management of chronic pancreatitis, and those behaviors that may exacerbate the history of disease also can be avoided. Then pancreatic enzyme supplement is the other part of the treatment. So the major part of the treatment now are pancreatic enzymes are given, analgesics, and monitor for hyperglycemia, because there is a possibility of involvement of the endocrine component of the pancreas. So if the endocrine component of the pancreas is involved, then the patient would have hyperglycemia, which needs to be treated. So it has to be monitored. What I have seen in my practice is such patients respond better to Agnitundi Aragyardini Kumari Asava. Of course, there is a spelling error. It should be Kumari, not Kunari. Kumari Asava are the other prescriptions which would give you better relief than even the pancreatic enzymes. That's about the chronic pancreatitis. The last part of the pancreatic disorders which we discussed would be the pancreatic malignancies. Now, pancreatic cancer is considered to be one of the common, and it's considered to be 10th most common cancer in men and 8th most common in women. But it's the 4th leading cause of cancer deaths because the outcome is poor. Though the incidence compared to the other malignancy is lesser, the fatal results are more. That suggests about a relatively poor prognosis of these pancreatic cancer types as such. The pancreatic cancer could be again categorized mainly into two categories: exocrine and endocrine pancreatic tumors. The most important is the exocrine component, that's the head and body of the pancreas getting involved, whereas the endocrine pancreatic tumors are comparatively lesser. So we will just refer to that in very casually about the endocrine. We will discuss about the exocrine component only. And among them, the most common 90% are of ductal adenocarcinomas, which have a relatively rapid course and they have a almost uniform involvement, and major portion of the pancreas involved in the ductal adenocarcinoma is the head of the pancreas. A head of the pancreas involved would present with obstructive symptoms of biliary drainage much earlier than the others. The other microscopic varieties of the pancreatic cancer are giant cell carcinoma, invasive adenocarcinoma, or mixed type where there would be both ductal or acinar, or mucinous carcinoma, pancreatoblastoma, papillary cystic neoplasms, or which also called as Brandt's tumor, or mucinous carcinoma, signet ring carcinoma, small cell carcinoma, undifferentiated carcinoma. These are all the histopathological variations of the pancreatic tumor. As far as the clinical presentation is concerned, there is not much of a difference, except that depending upon the location, if the tumor is located in the head, the obstructive symptoms of biliary obstruction would be seen much earlier, whereas elsewhere they may not be. And otherwise, these variations are of importance only from the histopathological point of view. As far as the causes are concerned, based upon the statistical incidences, alcohol is one of the most common cause for the pancreatic cancer. 40% of the patients of pancreatic cancer, the alcohol relationship is identified. Chronic pancreatitis also is known to trigger pancreatic tumors later on. So that constitutes around 40% and 40% total 80%. Alcohol and chronic pancreatitis constitute around 80% of the condition. Smoking is and other lifestyle factors like alcohol consumption. Smoking is also considered to be one of the other causes, which are seen in about 30% of the patients as such. Hereditary syndromes, family history of pancreatic cancer, or obesity also are considered as the causative factors. Clinical presentation can be of quite wide varying clinical symptoms. The most common clinical symptoms would be significant weight loss. Patients tend to lose weight without any other specific causes. Such patients have to be investigated for pancreatic cancers. Patients may have an mid-epigastric pain, and it's also a common symptom of pancreatic cancer, sometimes with the radiation of the pain to the mid-back or lower back region. Pain which occurs at the night time, often a predominant complaint. Onset of diabetes mellitus within the previous 2 years could also be one of the maybe the guideline or maybe the suggestive factor for pancreatic cancer. So a patient who is diagnosed to be diabetic recently, if the patient has these symptoms like pain in the abdomen, weight loss, etc., has to be again carefully investigated to rule out the pancreatic cancer. Patients who have obstructive jaundice, painless obstructive jaundice, as I told you, it's the most common early symptom in case of tumors of the head of the pancreas. They are rather more common, incidence-wise also more common. Adenocarcinoma of the head of the pancreas is more common. Pruritus as a result of the jaundice also is a characteristic trait. Other very characteristic clinical signs which are often considered as the major salient signs of pancreatic cancer are Trotsky sign and Curvaser sign. But it's important that though it's considered to be in the textbook, it is considered to be like the most important signs of pancreatic cancer. They are not seen in all patients. They are seen only in a few of the patients where maybe the cancer is quite advanced. It's due to the thrombophlebitis and deep vein thrombosis that the patient may have the spots, reddish color spots around the body due to the blockade of the circulation over the surface as such, which also could be seen in case of acute pancreatitis. So, though it's considered to be the most important clinical signs, from the practical clinical point of view, Trotsky and Curvaser sign have a very limitations, because one, they are seen in only advanced conditions of pancreatic cancers, and when the signs are present, they could be more positive than the absence of the signs doesn't rule out the cancer as such. That's the important point. If the patient may have ascites also can be present, abdominal mass and hepatomegaly due to the metastasis in the liver also could be presentation of the pancreatic cancers, or pancreatic cancers also present with the metastasis as such. Pancreatic cancers are staged into T1 is when the size is less than 2 cm, T2 is more than 2 cm, and when it invades the stomach and spleen or larger arteries, then it is considered invades into the duodenum or bile duct, it is considered T3. If it is invading into the vessels beyond the compartment of the GIT, then it is considered as T4. That makes the prediction of the prognosis as such. The progression of the cancer in pancreas is very classical. Like it will be just initially small one, and then it reaches the stage 1A that involves the structures nearby, and even the structures of vessels in the periphery also could be involved, and even there could be metastasis in the liver as such. As far as the treatment is concerned, there is no definite curative treatment. The pancreatic duodenectomy or Whipple procedure is considered as the option of the treatment, which is supposed to have better results, but practically the outcome of this procedure also is not very good, and total pancreatectomy or distal pancreatectomy are the other options of the treatment. Chemotherapy also is one of the options. Relative 1 year survival rate of pancreatic patients with pancreatic cancer is only 28%, and the overall 5 year survival rate is just 9%. having increased from 3% between 1975 and 1977. This is the data from the global data. So the important is the summary of what we can message, what we can make is the outcome of pancreatic cancer is extremely poor as such. Then the last part of our discussion would be neoplasms of endocrine pancreas. Again, there are many varieties, but we will not discuss all. We will refer to only some of them which are moderately important. In general, the endocrine pancreatic tumors are comparatively less common, and only a few of them have some importance. Insulinoma, gastrinoma, Zollinger-Ellison syndrome, or gastrinoma itself also is a Zollinger-Ellison syndrome, or lipomas, or WHA syndrome, and glucagonoma, or somatostatinomas are varieties of the tumors. We will not discuss all that, but certain of the conditions which may have some clinical significance incidence-wise is insulinoma. Insulinoma, though not very common, there is a possibility that we may see such patients. When the patient has a severe hypoglycemic symptoms, where the patient's blood sugar level goes less than 50 milligram, even when the patient is not on any anti-diabetic treatment, or if the patient's symptoms are relieved by a glucose administration, then we consider as a possibility of insulinoma, and particularly this is true in pediatric conditions. In children who develop this kind of a symptom quite frequently, you have to suspect the insulinomas in such conditions. And the other symptoms produced due to the insulinomas, they are again categorized into two categories: the neurohypoglycemia symptoms and the abnormalities of the adrenergic system as such. The neurohypoglycemia symptoms are headache, lightheadedness, confusion, visual disturbance, seizures, particularly in children. When the children present with atypical seizures, one of the possibilities could be hypoglycemia induced due to insulinomas. So in pediatric practice, insulinomas have some significance, and when the patients present with those three set of the symptoms like hypoglycemia, which is relieved by the glucose administration and the level is less than 50 milligram, which is called as Whipple's triad, we have to suspect the insulinomas more importantly than others. And even children may have personality changes, or maybe even comatose conditions could be presented as such. The adrenergic symptoms or catecholamine-induced symptoms are palpitations, weakness, trembling, sweating, tachycardia, and irritability could be the other symptoms seen in case of pancreatic insulinomas. So, of course, there is no definite curative treatment in all the conditions. Diagnosis has to be made, and the treatment has to be provision of sufficient glucose. And when it's identified, surgery is the only other options in such conditions. Insulinomas, it's a rare condition, not a very frequent condition. The next condition which we refer to would be the gastrinomas or Zollinger-Ellison syndrome. Now, it's a Zollinger-Ellison syndrome or gastrinoma is produced due to a minute tumor. Usually the size of the tumor is just less than 2 millimeter. So, mechanical identification of that would be quite difficult. Only a perfect MRI scan can make out that. But the patient would present with multiple gastric ulcers, particularly ulcers in the duodenal area, beyond the bulbar area, duodenal bulb area. If there are multiple ulcers, that is a suspicion for the Zollinger-Ellison syndrome. So, patient presents with the symptoms of peptic ulcers, and there could be evidence of multiple peptic ulcers, and those peptic ulcers which are refractory to the medical therapy, usual treatment. Patients who tend to have recurrence of ulcers after the surgery, ulcers accompanied with diarrhea or prolonged unexplained diarrhea also could be one of the possible clinical symptoms of the Zollinger-Ellison syndrome. So, patients who have peptic ulcer pathology and it becomes resilient to the other treatment. And if the ulcers are multiple seen on gastroscopy, you have to suspect Zollinger-Ellison syndrome, and there you will have to go for MRI scan and then maybe if possible identify the tumor. Once the tumor is identified, the only option of the treatment is a surgical treatment. There is no question of any medical treatment as such. The symptomatic treatment like proton pump inhibitors may not be really helpful. Then another rare condition not common is a glucagonoma, where the patient may have increased glucagon secretions, where the blood sugar level may be higher than normal, may present like diabetes, but not a primary diabetes, where the insulin secretion may be normal. The patient's clinical presentation often would be skin pathologies, dermatitis, ulcers in the stomach, weight loss, anemia. So practically, diagnosis of glucagonoma from the clinical point of view is extremely difficult, not possible. Only in the advanced setups where there are some major clues about the possibility of increased glucagon hormone level, it can be identified. So not much important. Another of the condition which can be misleading is the carcinoma tumor. Carcinoma tumor is produced due to argentapping cells present in GIT anywhere. It is not only in the pancreas. The carcinoma tumors can occur anywhere in the GIT, and they are known to produce histamine, release histamine repeatedly, and because of the histamine release, the patients may have acute histaminergic reactions like itching, rashes over the body. So patients presenting with that episodes of rashes, itching, flushing over the body or diarrhea, you have to suspect carcinoma tumor. Incidence of the carcinoma tumor in pancreas is much higher than the other part of the intestines. It can occur even in the appendix. Carcinoma tumors are also known to present in the appendix, small intestines, elsewhere too. But as far as the statistical incidence, it's common in the pancreas also. The valvular lesions in the heart, particularly tricuspid valve pathology. Tricuspid valve pathology is very characteristic of the carcinoma tumor. Patients may have episodes of cramps. There could be vascular pathologies, telangiectasia, like peripheral vascular blockades can occur, and hence reddish patches could be seen. Peripheral edema, episodes of wheezing, cyanosis, or even arthritis can be presented. So patients who present with the symptoms of repeated flushing which do not respond properly to the so-called antihistamine treatment, they have to be investigated for the carcinoma tumor. Again, the treatment would be surgical. There is no question of medical treatment. The other types of endocrine tumors, they are less important, and hence we will not go into that much as such. So with this we will conclude the pancreatic diseases as such, and we will conclude the Annavaha Srotas diseases also. Next part we will discuss about Udakavaha Srotas pathology. So if there are any questions, I will try to answer, and then we will just wind up today. How can we treat pancreatitis? It's as good as any other diabetes mellitus. We will have to provide insulin. Say pancreatitis induced hyperglycemia is a insulin dependent condition. So insulin is the only option there as the treatment. Of course, our medical treatment like Asanadi, such drugs also can be given, but ideal treatment is insulin, and it's a insulin dependent condition. That's the issue. Right. Okay. Any other questions? Right. So we will conclude today, and we will continue with the Udakavaha Srotas in the next session.